Madam, we are live now. So good evening, doctors. Yes. So good evening, doctors. I, Shuman, on behalf of Shield Healthcare, welcoming you all in today's a very important and important topic that is high risk pregnancy. And our guest speaker is Dr. Yamini, madam. Madam did her MBBS, DGO, MRCOG, and madam is the consultant gynecologist, Kiran Hospital, Kurnool, Andhra Pradesh. So with this short introduction, I request madam to take over the session, and meanwhile, I request all the participants for your active participation, and please drop your queries on the dashboard of the Shieldconnect page. So once the talk will be over, we shall have a short discussion on this very important topic with madam. So thank you very much, madam, once again for your valuable time on our platform Shieldconnect to discuss such an important topic. And over to you, ma'am, for further proceedings. Thank you very much.
Yeah, thank you, Suman, for your beautiful introduction about me. Now, I don't want to waste much time because it's a vast topic which can't be covered in just an hour. So, good evening, friends, my colleagues, my seniors, my doctors, my juniors, everyone, my friends. So, today's my topic is high-risk pregnancy, which everyone know it's a very vast topic which can't be, which can't be covered in just 1 hour. So that's, but let me shortcut the topic by stressing a few points in high-risk pregnancy. So what is a high-risk pregnancy? As you all know, every patient is a nightmare to an obstetrician. Everyone know that, because each and every case or each and every patient is treated as high risk unless until diagnosed otherwise, because the patient antenatally, if you screen each and every patient according to your norms, according to the books, according to your senior colleagues, whatever, most of the cases may land in risk during delivery, during cesarean, during surgeries, or postnatally or post-operative. You feel many, you face many complications after the operation or after the delivery, that is postnatally. So each and every patient should be screened well and good, because many things we can get about in screening. That is, when you take the proper history, that is proper medical history, proper personal history, proper past history, family history, obstetric history, each and every history, if you deal, if you concentrate on the patient, then most of the problems you could anticipate antenatally itself. You could know antenatally, and you can deal in a very perfect systematic manner during delivery or after delivery also. So what is high risk pregnancy? High risk is nothing but if the mother is at high risk, or fetus is high risk, or if both mother or fetus, or mother and fetus are at high risk of increased risk of morbidity or mortality before delivery, during delivery, or after delivery, then it's considered as high risk. And one more thing is, pregnancy places additional physical, emotional burden on a woman's body. So each and every, so these are the problems what we face in high risk cases. Let me know some of the, let me get in detail about some of the complications in some of the entities what we face in day-to-day practice. So in high-risk cases, so first one is, before going into high-risk cases, or before bombarding into the various parameters in high-risk cases, let me stress about few points what we do during pregnancy. That is, what screening tests we do during pregnancy in first trimester, second trimester, or third trimester. What are the screening tests which we deal during pregnancy? So the first trimester screening test, what we recommend generally is recommended is, so weight of the patient should be noted, BP, hemoglobin status, that everyone know that these should be dealt in each and every patient. So blood group and R-head status of both the partners should be dealt. Urine routine, urine microscopy, VDRL, hepatitis, HIV, thyroid, TSH, DIPSI, that is urine routine, dating scan. First dating scan should be done in first trimester. After dating scan, go for if you are in doubt, go for not a doubt, but every patient should be treated as a high risk patient, and nuchal thickness scan should be done. So if after counseling, if they accept prenatal testing, you should go for NIPS, that is non-invasive prenatal testing, and cervical length should be noted in first trimester itself. These are recommended tests before in routine antenatal screening. Preferable tests are, recommended tests are all these things. Preferable tests are body mass index, mean arterial pressure, complete blood picture, smear, that is peripheral smear electrophoresis, urine culture, rubella IgG antibodies, thyroid function test, thyroid antibodies test, HbA1c test, oral glucose tolerance test, blood sugar, uterine artery Doppler, and placental growth factor if necessary. Nowadays, everyone know that after COVID pandemic, each and every case is dealt with in a COVID positive case. So always COVID, if at all you doubt whether the patient is COVID positive, always perform the COVID test. So, and in second trimester, so recommended tests are, so always repeat blood test if you are in doubt whether the patient has anemia, or whether the blood sugar levels, or patient is in risk of diabetes. Always repeat blood tests, hemoglobin, blood sugar, urine albumin sugar deposit, and go for quadruple marker test, and make note of cervical length. So preferable, again in second trimester, the preferable test is uterine artery Doppler, 3D 4D scan, fetal echo. These are the tests which are preferable in second trimester. So in third trimester, which are mostly recommended are repeat these blood tests, urine dipstick test, TSH test, like go for growth scan, then go for placental localization, see the liquor whether it's sufficient, then fetal movements should be monitored in third trimester. So preferable, again, these are the recommended tests. The preferable tests are Doppler velocimetry, color Doppler. So all pregnancies should be offered all these tests, in first trimester, second trimester, and third trimester. These tests should be always prescribed to the patient, because preferred to the patient, because you in future medical legal cases, if you are landing in medical legal problems, always these tests should be done, so that you can argue with the in the future. So always these cases should be done. Slides, slides. So after the antenatal screening test, what are the routine vaccinations we advise during pregnancy? Strongly recommended, everyone knows that is toxoid inactivated vaccine, that is Tdap, that is tetanus toxoid, and diphtheria toxoid are definitely should be recommended in pregnancy. And recommended in special inactivated influenza vaccine is also recommended. Can be given at any stage of pregnancy, that is inactivated so inactivated vaccination can be recommended, that is influenza vaccine. So recommended in special situations, what are the vaccines we recommend during pregnancy in special situations are pneumococcal vaccine and post-exposure prophylaxis. Whenever the patient is exposed to rabies, hepatitis B, hepatitis A, if you are in doubt, better to give in post-exposure prophylaxis. The vaccines which are strongly not recommended during pregnancy are live vaccines, such as oral polio, HPV, BCG, MMR. These are not recommended in pregnancy, as these are live vaccines. One more vaccine is rubella, is also not recommended, but nowadays some of the studies concentrate on rubella vaccine. So some more studies are going to come whether the rubella vaccine is recommended during pregnancy, is safe during pregnancy. There is no enough studies. So postpartum vaccination after delivery, immediately after the delivery, if Tdap is not given earlier, you can opt for Tdap. HPV vaccination, if not done earlier, can be given. Immediately after the delivery, MMR and varicella, if the patient is in exposure or is in alarming condition, then you can prescribe these vaccines. So, as I have already said, pregnancy, including labor and delivery, is itself a high-risk event. So, what is the aim to detect risk assessment is to identify the factors that may constitute greater than average risk to a pregnancy. So, this permits the prediction of potential adverse pregnancy outcomes so that we can concentrate on that approach, whether she has PAH, whether she's going into land into GDM, or whether it's bad obstetric history, the patient had a bad obstetric history, or the patient is entering into post-mature state, or the patient had any complications of preterm deliveries, premature labor, premature rupture of membranes, or recurrent pregnancy losses, or post-cesarean or placenta previa. These are all the risk factors which can be anticipated and which you can have hand-in-hand approach to the patient so that you can have adequate facilities at your setup. If for example, if you are going to face the patient with anemia, then make sure that the blood transfusion products are in hand. So these are all the examples, because that's why the risk assessment is important for each and every patient. So what are the causes, major causes of maternal mortality everywhere worldwide, and most probably in India? In India, the first place goes to anemia, because anemia is the direct cause of maternal mortality, or indirectly it leads to PIH, it leads to many other complications like sepsis. So anemia is the major cause. Then comes PIH, then comes eclampsia. PPH, anemia always leads to PPH, and BPH is again a major topic which can be dealt separately. So puerperal sepsis, which nowadays has been decreased in incidence, because most of the antibiotics we routinely give works are doing wonders in pregnancy. Obstructed labor, whenever the patient comes from peripheries to tertiary center, most of the cases are in obstructed labor. So more chances of injury to the bladder, injury to the bowel, injury to the adjacent structures around the uterus. So these cases are definitely leading to maternal mortality because of again sepsis, because most of the patients land in sepsis. Unsafe abortions which are carried by midwives or RM, registered medical practitioners, whoever. Whenever the patient goes to them directly without coming to an obstetrician, most of the cases land in unsafe abortions, and many abortions at peripheries are concentrating on female feticides. So most of the patients always elicit the history whether they are given any tablets or IV fluids at the peripheral center whenever you encounter such cases. So as I have already said, these are all the high-risk conditions of pregnancy which we encounter in day-to-day practice. That is severe anemia, hemoglobin less than 7 grams, pregnancy-induced hypertension, PAH, preeclampsia, preeclamptic toxemia, which leads to eclampsia, gestational diabetes, syphilis and HIV positive. Syphilis nowadays we are seeing at most almost in a meager number. I haven't seen any single case of VDRL positive in my practice. So syphilis is on a decreasing trend, but HIV positive, mostly because of awareness or anything, HIV is also decreasing in trend. Nowadays, COVID is on increasing trend. So this syphilis or HIV positive can be COVID is alternative to this, because COVID positive, most of the cases we dealt in first wave and second wave of COVID, and most of the patients, if now also if they are in if they complain about upper respiratory tract infections and lower RTI, go for COVID test once before you start the treatment, because you'll be on safer side. Hypothyroidism is an increasing trend. Hypothyroidism not only hinders the health status of the patient, but also baby's risk is also, fetus risk is also increased in hypothyroid mothers. Young primary, which almost less than 20 years, in some communities you see the patients the females getting married at the age of 16 years, at very early age, and are elderly gravida. So in metropolitan cities, most of the women, they go for pregnancies or they go for family things after they are being settled in their career. So most of the cases are elderly gravida or young preemie. Young preemie you will see in peripheral situations. So twins or multiple pregnancies, malpresentation, whether it is a breech or whether it is a malpresentation is transverse slide. So previous LSCS, nowadays LSCS is an alarming increasing trend. So each and every post-seizure patient is a high risk patient. I mean, is to be considered as a high risk because as everyone knows, previous LSCS post-seizure you may see placenta accreta, low-lying placenta, or you may have some complications while delivering the patient. I mean, while operating, you may injure the bladder, you may injure the ureter. So whatever. So previous LSCS is a normal thing what we encounter in each and every day. Low-lying placenta and placenta previa. That's what previous LSCS always you make sure that the placental position is at the upper segment, because if it's placenta previa, that is if it's at the incision site, it's again life-threatening or alarming situation. Or if it's at cervical loss, I mean less than 2 centimeters from cervical loss, always you mention to your radiologist about the placental status, that is whether it is placental accreta, increta or percreta, because most of the post-cesarean or most of the post-DNC cases, whenever you encounter the placenta low-lying, make sure that the placenta is not in the status of increta, percreta or accreta, because the management is completely entirely different in both cases. And positive bad obstetric history, that is if you had if the patient had history of stillbirth, previous abortions, either first trimester abortions or second trimester abortions, or any congenital malformation of a baby, you take a proper history. What is the congenital abnormality I mean you encountered, that patient has encountered. Make sure that all the investigations are being carried out in previous pregnancies or right. I mean, whether the radiologist has done a perfect job or not. So always you take the history and positive bad obstetric history, whether the patient had history of obstructed labor, whether the patient had history of baby had history of premature birth. So these all things you could elicit in obstetric history. And RH negative status, whenever you go for investigations, that is screening tests, always make sure that blood grouping should be performed each and every first time. If the grouping is negative, the husband's group should be done, and if both the husband's group is positive, then go for indirect Coombs test for the patient irrespective of the gravida status. So patient with history of any current systemic illness or past history of illness, nowadays most of the cases had are landing into chronic hypertension, diabetes predisposing, all should be elicited. So, and first one is always most of the cases, as I have already said, the first one is anemia, second one is hypertensive disorders. So hypertensive disorders complicate around 10% of pregnancies. So as you all know, hypertension is defined as BP when the recording of BP is more than 140 to 90 to consecutive readings at any time of the pregnancy. So always on 2 occasions, if PAH is defined as when the systolic blood pressure SBP is greater than 140 or greater than or equal to 140, or diastolic greater than or equal to 90, on 2 occasions at least 4 hours apart after 20 weeks gestation in a woman with previously normal blood pressure, that is considered as PAH. So whenever the PAH is combined with proteinuria, then always the preeclampsia should be kept in mind. So preeclampsia without severe features is the blood pressure, as I have already said, these blood pressure more than 140/90 plus proteinuria. Proteinuria is dipstick reading of 1 plus or protein creatinine ratio greater than or equal to 0.3 is considered as positive proteinuria, which should be kept in mind. So always if the 24-hour urine collection, if you see if there is more than 300 mg of proteins in 1 day urine collection, always the proteinuria can be suspected. So types of hypertensive disorders, everyone know that. I don't want to concentrate on the definitions and risk factors, because I want to stress the points about management. How do you manage, how to treat the patient whenever these complications you encounter. So chronic hypertension, that everyone know, if the hypertension, if you diagnose before 20 weeks, then it's chronic hypertension. It may be complicated by preeclampsia, then there is proteinuria as well. So pregnancy induced hypertension, as I have already said, when it is after 20 weeks of gestation. Preeclampsia, when the blood pressure is more than 140/90, associated with proteinuria more than 3 grams per deciliter in 24-hour specimen, or with proteinuria 1+ or 2+. So severe preeclampsia, where the blood pressure is more than 160 by 110 with proteinuria 3+ or 4+. And eclampsia is the occurrence of generalized convulsions usually associated with background of preeclampsia, either during pregnancy or labor or within 7 days of delivery. Whenever the patient you encounter the generalized convulsions, always rule out eclampsia. So you all know that likely complications of maternal and fetal: maternal complications, HELLP syndrome, ARDS, renal failure, pulmonary edema, DIC; fetal complications, IUG or IUD. So I want to concentrate on monitoring. So what to do whenever the patient comes with PAH in these things. So I want to stress about the risk factors for preeclampsia. So first I want to go for risk factors, because which patient to be anticipated, which patient is going to land in preeclampsia, you should know. So low risk factors are previous uncomplicated full-time delivery is a low risk factor. Moderate risk factors are nulliparity or age greater than 35 years, obesity, family history of preeclampsia, socio-demographic characteristics, and personal history. High risk factors are hypertensive disease during a previous pregnancy, multifetal gestation, chronic kidney disease, autoimmune diseases such as SLE or APLA syndrome, type 1, type 2 diabetes, chronic hypertension. These are all high risk for preeclampsia. So how do you reduce the risk for hypertensive disorders in pregnancy? So no need to give antiplatelet agents for all the cases. Recommendations are only to be given for only the aspirin should be 150 mg should be given for moderate risk or high risk patient. Do not recommend aspirin for low risk patient. No need to recommend aspirin in each and every cases. So always give antiplatelet agents for high risk and moderate risks. That is, aspirin 150 mg per day should be given from 11 to 14 weeks, or whenever the fetal heart rate is first established in your ultrasound, you can start the aspirin until 36 weeks of gestation. Some school of studies also recommend aspirin, low dose aspirin 75 mg for about 28 weeks. But nowadays, aspirin 150 mg can be given for 36 weeks. So, and one more thing is, you stress upon calcium supplements. That is, calcium supplements 1200 mg daily. If dietary calcium intake is low in the local population, always increase your calcium intake. Increase the calcium intake of the patient. So, and one more thing is, pregnant women should exercise at least 3 days a week. These are all the factors you should always monitor in the patient, and you should always advise to the patient. That is, the pregnant women should exercise at least 3 days a week for an average 50 minutes using a combination of aerobic exercises, strength exercises, flexible training exercises. This always leads to reducing incidence of complications. So nutritional supplements which are not recommended in preventing are antioxidants, fish oil, folic acid, magnesium, garlic, nitric oxide donors. These are the drugs. Progesterone, diuretics, low molecular weight heparin. These are not recommended to prevent the PAH cases. And most important point is, do not recommend salt restriction during pregnancy solely to prevent gestational hypertension or preeclampsia. So normal salt intake can be advised. No extra added salt can be given. So always, according to FIGO recommendations, all pregnant women should be screened for preterm preeclampsia. So what are the recommendations they have advised is: maternal risk factors, mean arterial pressure, uterine artery pulsatility index, and placental growth factor is as a one-step procedure can be advised in first trimester and second trimester, which you can detect preeclampsia in first as a first-hand information. So, but low or middle income countries like India, so baseline test should be maternal risk factors combined with mean arterial pressure. What is mean arterial pressure is 1/3 of SBP plus 2/3 of DBP is mean arterial pressure. So you always concentrate on mean arterial pressure in low socioeconomic status people, so that you can prevent the you can anticipate the preeclampsia risk factor. So ideal, and one more thing is each and every case we forget how to take BP measurements. This is very important in each and every practice, because the BP recordings are changed from one doctor to another doctor, and the patient is apprehensive why the changes are occurring. So always ask the patient to empty the bladder and come. So make sure the BP recording should be given in the taken in the quiet environment and comfortable room. No tight clothing on upper arm or forearm is advised while taking the BP. BP should be measured with the women in sitting position with the arm at the level of the heart. Cuff size has to be appropriate, that is the breadth of 1.5 times the circumference of the arm. No acute anxiety, stress or pain is encountered while BP recording, so is not to be encountered. No caffeine, smoking or nicotine in the preceding 15 to 20 minutes. Patients should stay silent prior and during the procedure. And one important point is no nasal decongestant and ophthalmic drugs are used before coming for BP checkup. These are all to be concentrated. So, as I have already said, management of hypertensive disorders. When you see the maternal assessment, that is management of preeclampsia, as I'm concentrating. Whenever the first line drugs are antihypertensive medications, what we regularly use are labetalol, oral methyl dopa. Second line drugs is nifedipine. Third line drugs is hydralazine. So the symptom assessment, physical examination assessment, laboratory assessment, all should be done, and delivery recording according to your protocol, whether the patient, according to the gestational age of the patient, according to the BP status of the patient, according to the investigations, you should go accordingly. So as you all know, eclampsia should be dealt very promptly, because the definitive treatment is nothing but delivery in eclampsia. So in pre-eclampsia, the definitive treatment is delivery, but one has to wait until lung maturity and gestational age is reached. So the cornerstone would be controlling hypertension, assessing the severity, monitoring the maternal fetal conditions, so and preventing the onset of eclampsia. Treatment with antihypertensives can be initiated at 90 to 100 mm Hg itself of DBP. So proper rest and high protein diet are recommended. As I have already mentioned, that methyl dopa 250 mg twice or thrice daily, nifedipine 10 to 20 mg orally, labetalol 100 mg twice daily is also effective. Prophylactic blood self, whenever you anticipate the eclampsia, in the setting of severe eclampsia, you can give, and all the patients should be advised 1 gram per day of calcium. So these are the biomarkers in first trimester, that is mean arterial, placental growth factor, uterine artery pulsatility index, PAP-A. These are all the useful biomarkers in first trimester. So universal screening should be done in all the pregnancies at 11 to 13 weeks with these biomarkers. When resources are limited, go for MAP. Treatment, women at high risk should be given a prophylaxis of 150 mg. So second is anemia. Everyone know how to deal anemia. So anemia is defined as hemoglobin level less than 11 grams, mild is 10, moderate is 7, severe is less than 7. So most commonly we encounter in is iron deficiency anemia. Even we see macrocytic anemia, which is not so important in day-to-day practice, but iron deficiency anemia we encounter in most of the patients. So what are the complications in maternal and fetal? Everyone know, which I don't want to concentrate because of lack of time. So diagnosis, everyone know the symptoms, what the patient comes. So how do you manage the patient? So Always give the prophylaxis of 100 mg elemental iron with 0.5 mg folic acid. Every iron molecule, each and every iron molecule has its own advantages and disadvantages. That is, iron sucrose is mostly preferred. Iron ferritate is also preferred. But most of the cases, we almost nowadays we give iron as ferrous ascorbate molecule. So in mild to moderate anemia, it can be treated by iron and folic acid, where 100 mg elemental iron plus 0.5 mg folic acid. So always, if you anticipate any anemia complications, always the HP level to be assessed monthly. So if there is any non-compliance or intolerance to oral iron, irrespective of gestational age, irrespective of trimesters, you can go directly to parenteral iron preparations. So moderate to severe anemia, so always first prescribe antihelminthic drugs like albendazole 400 mg single dose, because hookworm endemic area is our country is hookworm endemic areas. So that is what the anemia is dealt with. Anemia can, so irrespective of gestational age, if the patient had severe anemia and if the patient had complications of impending heart failure, go for blood transfusion irrespective of the trimester. Always keep in mind of blood transfusion. But first trimester and second trimester, if the patient has good compliance with iron sucrose injections, first make sure that iron sucrose injections work. If that doesn't work, then go for blood transfusion. So one more thing is I want to concentrate in anemia is so always go for complete blood picture in the patient, so that you can know each and every status of the patient. So blood transfusion, I want to stress about indications for blood transfusion, because where in whichever cases you advise blood transfusion is severe anemia with impending heart failure in any trimester, severe anemia in any trimester with signs of heart failure, near term moderate to severe anemia, moderate to severe anemia in labor, anemia due to hemoglobinopathies, anemia due to acute obstetric hemorrhages. These entities are always dealt with blood transfusions. So next topic is twins or multiple pregnancy. I'm in a rush because so many topics are to be covered in high risk pregnancy. It is a vast topic, so I want to concentrate just few points which are very important in our practice. So twins or multiple pregnancies are an increasing trend because of widespread practice of ERT techniques. So whenever you suspect whenever the fundal height is more than period of gestation, an ultrasound is done to know the diagnosis of multiple pregnancies. So all the twins or multiple pregnancies are dealt as high risk because most of the cases may land in preterm labors, preterm deliveries. Again, the patient may land in postpartum hemorrhage. Again, the patient may encounter anemic status or PAH or postpartum hemorrhage. So each and every multiple gestational pregnancies are to be dealt as high risk. Placenta previa. This is also very much important and which is on increasing trend because of previous cesarean sections. We mostly encounter these cases nowadays. So what is placenta previa? That everyone knows that the implantation of the placenta wholly or partly in the lower segment of the uterus is nothing but placenta previa. So important cause of perinatal mortality in placenta previa is mainly due to prematurity. Because most of the cases we advise that if the patient lands in bleeding, we regularly advise the patients to go for termination. So what is the incidence is 4 to 5 per 1,000 pregnancies. So classification depends upon the relation of the internal os and the placental position, whether it is related to anterior or posterior wall. Always keep in mind that the anterior placenta previa, you need not worry. You keep the blood transfusions in hand so that if they are needed during delivery or during antenatally. But most of the anterior placentas are calm. No need, placenta previa are calm. No need to worry. Posterior placenta previa are worrisome because most of the posterior placenta previa may land in PPH. So Everyone knows that increased maternal age, multiparity, uterine scar, multiple pregnancies, previous abortions, previous DNCs, all leads to placenta previa. So what is the diagnosis? Painless bleeding PB, uterine height, as everyone knows that it's corresponding to gestational age, but soft non-tender uterus. What is the difference between placenta previa and abruption is, abruption, you see painful bleeding, tender uterus, and you won't see the fetal heart pulsations. In most of the cases, the patient may land in IUD. But here, the placenta previa, the fetal heart is very well known, but the abnormal presentation, because of placental position, the fetus may be in abnormal mal presentation or mal position. So warning bleeding in each and every trimester should be taken seriously, and the ultrasound location of the placenta should be confirmed. So always the management, no PV to be done. Always go for hemoglobin and blood transfusion if necessary. Routine antenatal checkups to continue till 37 weeks if the patient is not in alarming condition. But if the patient goes into labor or heavy bleeding, irrespective of the gestational age, the pregnancy should be terminated. So here the placenta previa cases, I want to stress about some points where we miss in day-to-day practice. So as I have already said, the antenatal women, the risk factors of placenta previa, previous placenta previa. If the patient complains of bleeding, go for placental position. So always make sure that whether it is lying placenta, marginal placenta, partial placenta previa, complete placenta previa. So if the placenta is greater than 2 centimeters away from the internal os, no need to worry. Normal follow-up is required in those patients. But if the placenta is less than 2 centimeters away from the internal os, follow-up scans up to 36 weeks, whether the placenta is going upside or when the uterus is growing, you see that. So ultrasound in central placenta previa, ultrasound Doppler and MRI to rule out morbidly adherent placenta. And there is no role of tocolysis or no role of cerclage in placenta previa. Correction of anemia with parenteral iron therapy should be done. These are all management protocols in placenta previa. In morbidly adherent placenta, what are the management protocols are? Ultrasound, if you are sure that it is morbidly adherent, whether it is accreta, increta, or percreta. Accreta is adherent to myometrium. Increta is invading myometrium, not beyond serosa. Percreta is penetrating through serosa. Always make sure that you explain risk to the patient about massive torrential hemorrhage, urinary tract damage, whether it is ureter or urinary bladder, whatever. But always anticipate bowel injury, need for massive blood transfusion, and hysterectomy. Always explain these risks to the patient and go for surgery. Multidisciplinary team should include obstetrician, anesthetist, urologist, neonatologist, and interventional radiologist, where he plays a role in uterine artery embolization or internal iliac artery embolization. So always planned elective preterm cesarean hysterectomy with placenta in situ at 35 to 37 weeks in morbidly adherent placenta. If you want to uterus to be conserved, in uterus conserving procedures, leave placenta in situ. Strict follow-up the patient with methotrexate and antibiotics, and you can go for, if the patient is opting for delayed hysterectomy, you can go for delayed hysterectomy afterwards. Syphilis nowadays, universal screening of pregnant women is not routinely done. Previously, Government of India has given a policy, but nowadays we not worry about syphilis because there is not at a increased risk of syphilis in pregnancy. So I want to skip off this syphilis. I want to stress about hypothyroidism. This is also a burning topic because prevalence of hypothyroidism in pregnancy in the Indian population is 4.2 to 12%. Hypothyroidism, whenever the patient comes for antenatal checkups, always screen the patient with thyroid function tests like TSH, FT4, that is free T4 should be done in each and every patient. So how do you diagnose the hypothyroidism in the patient is clinical signs is fatigue, constipation, everyone knows. I don't want to stress about those points. So where is how do you anticipate the which test what to with what test you can come to conclusion about thyroid complications? So what tests to order? So suspected hypothyroidism, you can go for TSH alone. For the routine investigations, routine antenatal screening, you can go for TSH plus FT4. Suspected thyrotoxicosis, if you anticipate any thyrotoxicosis in the patient, go for FT3. Follow up of T4 hypothyroidism, you can go for TSH. So these are all the tests you regularly prescribe, I mean you regularly advise to the patient. So what the thyroid function test, what is normal? So whenever the TSH in first trimester is 0 to 1.6, second trimester is 1.1 to 1.8, third trimester is 0.0 to 3. These values are normal, which you should be kept in mind. So whenever you see the problems, I mean you see the deranged values, if there is a risk factor for thyroid disease, go for TSH levels. If the TSH is less than 3, no need to worry, euthyroid, no further workup is recommended. But if TSH is more than 3, repeat TSH, FT4, TPO, that is thyroid antibodies. Start levothyroxine following blood draw while awaiting lab results. So you can start if you anticipate TSH more than T3 before you get FT4 TPO. So you start levothyroxine. So repeat labs if tests are normal. Stop levothyroxine, no further workup is required. But if TSH is more than 3 and normal FT4, you suspect subclinical hypothyroidism, start levothyroxine. If TSH is more than 3 plus you see TPO and low FT4, you start levothyroxine and make sure that TSH is between 0.5 to 2.5. So recheck TSH levels between 4 to 6 weeks and adjust the levothyroxine dosing. That is very much important in thyroid status of the patient. So this is this is about thyroxine, because we stress about thyroid test during pregnancy, because most of the patients have a repeated if they had bad obstetric history like repeated abortions, we stress about thyroid tests more often. So nowadays thyroid is on increasing trend. So if you have history of previous thyroid dysfunction or goiter or mental retardation in family or previous baby, or history of recurrent miscarriage, stillbirth, preterm delivery, abruptio, history of infertility, always screening of thyroid should be done in a proper manner. So these are all the things we should we should keep in mind. These all things should be kept in mind. So everyone knows that in management, levothyroxine is the drug of choice, which is taken in empty stomach in the morning. Once treatment started, TSH levels should be repeated after 6 weeks of the starting date of treatment, and the TSH levels always should be kept between less than 2.5. So the next topic is gestational diabetes. Gestational diabetes, as you have already is an increasing trend in normal population and also in routine pregnant women. This gestational diabetes, always the testing of GDM is recommended twice during antenatal checkup. That is, whenever first visit the patient comes, you should go for blood sugar levels and should be repeated at 26 weeks. So the first testing should be done at first antenatal contact, and second test should be done at 24 to 28 weeks. There should be at least 4 weeks gap between the two tests, and the test to be conducted for all pregnant women, even if she comes late in pregnancy, because you should not miss the gestational diabetes. So if she presents beyond 28 weeks of gestation, only one test to be done in the first point of contact. So universal testing for GDM. Everyone knows that testing of GDM at first antenatal visit is 75 grams oral glucose monitoring test. So oral GTT test is advised. If it's positive, manage as GDM as per guidelines. But if it is negative, repeat testing at 24 to 28 weeks. Then if it again comes positive, again go for 2 hours postprandial test. So again manage as GDM guidelines. If it is negative, manage as normal antenatal checkups. So pregnant women with GDM first go for medical nutrition therapy. That is nutrition, exercise, lifestyle changes you advise. After 2 weeks, Repeat the 2-hour PP postprandial glucose levels. If less than 120 mg, no need to worry, you go for medical nutritional therapy. So if greater than 120, start insulin. Monitor FPG, and 2-hour 2-hour and third day or more frequently, insulin dose is adjusted to maintain the blood glucose levels. So patient management is patient education, glycemic control, pharmacological therapy, fetal monitoring should be done by ultrasound, planning on delivery, medical nutritional therapy. So counseling tips, what you generally give according to national guidelines, they can be easily controlled by diet and exercise. Only in few women in whom blood glucose is not controlled by diet, exercise, injections and medications are required. Insulin injections are required only during pregnancy. Insulin will be stopped, requirement will be stopped soon after the delivery. So you make sure that glucose levels are checked soon after delivery, so that insulin should be stopped, because the patient may land in hypoglycemia. GDM cannot be treated with, most of the GDM cases are not treated with oral tablets, because most of the tablets are harm the fetus, except metformin. But if you are injecting insulin over the abdomen, it is safe. So modification of the diet is very important. If blood control, blood glucose is controlled, no need to worry about the mother status or baby status. So pregnant women with GDM should deliver at health facilities. It will help in management of any complications if you encounter. So these are all the recommendations. Generally recommended testing 4 times daily, that is fasting after each meal. So monitor glucose daily, monitor fasting daily. If the patient has GDM, these are all the treatment protocols. So if the goal should be kept in mind, that is 1 hour postprandial is always should be less than 140, 2-hour postprandial should be less than 120, fasting should be less than 105. And last but not least, these 2 things are pregnancy with previous cesarean section. As I have already said, most of the cases are landing in cesarean. So most of the cases you are dealing with previous cesarean sections. So about 15% of the pregnancies suffer from major obstetric complications. Near 10% of the total delivery cases may require cesarean section. So what are the risks of mother in post-cesarean cases or impending or uterine rupture, placenta previa, placenta accreta? Incident morbidity may occur during pregnancy, labor, or bladder discomfort may occur. Risk to fetus may be because of preterm delivery and low birth weight. So as I have already said, due to extreme operative complications, you can encounter technical difficulties, increased chances of injury. So last points regarding babies are intrauterine growth retardation. So intrauterine growth retardation is again a separate topic, which should be dealt. So I want to stress few points. It is referred to birth weight below the 10th percentile. Etiology is again preeclampsia, long-standing DM, placenta previa, pre-pregnancy weight less than 50 kgs, nutritional deficiency, particularly protein intake. So whenever the SFH height is less than what you anticipate, then measurement anticipate the IUGR. So IUGR is suspected if the fundal height is less than 3 centimeters and maternal weight gain is less than 500 grams per week. So risk factor, whenever you anticipate the small for gestational age or IUGR, so risk factors, what are the risk factors is maternal age more than 35 years, IVF singleton pregnancy, nulliparity, BMI less than 20, BMI more than 35, smokers, low fruit intake, previous preeclampsia. These are all the pregnancy interval less than 6 months, more than 60 months. These are minor risk factors, but major risk factors are maternal age more than 40 years, smoking, daily vigorous exercise, previous stillbirths, chronic hypertension, diabetes, renal impairment, heavy bleeding, APLO. These are all major risk factors. So always uterine artery Doppler should be done at 20 to 24 weeks, because you should assess the fetal size, and umbilical artery Doppler should be done in 3rd trimester to know the IUGR, to prevent the IUGR status. So serial assessment of fetal size and umbilical artery Doppler from 26 to 28 weeks is also advised. So this is, we generally see how the fundal height So non-stress test can be done during the last 3 to 4 months of pregnancy. It takes about hardly 20 to 40 minutes. It evaluates the fetus without causing any stress. So we all know that accelerations, if you see, you need not worry. Fetal movements, if you encounter during the non-stress test, it is very well and good. But if you see the decelerations, always rule out, always go for a scan, go for take Leica amount, A5 volume should be calculated, and uterine artery Doppler should be done, and make sure that the fetal kick count is not less than 10 in per day, and educate the patient about fetal kick count. And so how do you manage? According to RCOG guidelines, always the SGA fetus between 24 to 35 weeks of gestation should receive a single course of antenatal corticosteroids when delivery is being considered. So umbilical artery Doppler is the primary surveillance tool in this fetus. So repeat surveillance tool of, repeat Doppler can be done if you suspect any problems. So always prevention is better than cure. So concentrate on female nutrition status, first pregnancy delaying, treating the chronic diseases and pregnancy-induced disorders. Protein supplementation should be given. Micronutrient supplementation should be given. So these are the warning signs we see and in high risk cases, that is fever more than 38.5 degrees, headache or blurring vision you see in preeclampsia, generalized swelling of the body and puffiness of the face, palpitations, easy fatigability and breathlessness at rest. This falls around cardiac disease during pregnancy, which I have not mentioned in this topic because of lack of time. Pain in abdomen, vaginal bleeding, reduced movements, watery discharge, frequent urination, or these are all the warning signs which are kept in mind when you deal the patient. So why it's worrisome to why it's obstetric emergencies you are worrying? Because the obstetrician is in worry because fatality rate is more difficult to treat, surgery rate is increased, hospitalization is prolonged, morbidity is more for both mother and baby. So what to do? Prevention, what to do? So early diagnosis, community awareness about antenatal care, early initiation of appropriate therapy, early identification and timely referral to tertiary center is very much important when you do anticipate complications. So antenatal care, you should advise the patient about periodic checkups, regular checkups. Risk factors should be identified and time treatment should be started early. That is, if you anticipate anemia, you give iron supplements or go for iron sucrose injections, whatever is needed. PAH, if you anticipate, you can go for prevention low dose aspirin or start antihypertensive medication. So always advise hospital delivery in those high risk cases. If the maternal complications are diagnosed early, you treat accordingly. So because to decrease the maternal and fetal mortality. So past obstetric history, what you should kept in mind is if there is any history of stillbirth, there is history of intrauterine death, bad obstetric history, preterm delivery, IUG or PB, severe PAH, always should be kept in mind. So life-threatening situations, what you encounter is history of PPH, antepartum hemorrhage, eclampsia, other complications associated with pregnancy. So physical examination, this you see pallor, abdominal examination. Gravidogram is nothing but partogram during labor or during delivery. If the patient is going to obstructed labor, you could prevent this. So each and every, irrespective of doctor, nurse, everyone can go for gravidogram, can have a graph. So can have a first-hand information with partogram. No need to have any other facilities. If the gravidogram or partogram is in your hand, you may anticipate the obstructed labor and you could cut short the delivery. So fetal life can be known by ultrasound. Fetal presentation can be known. Fetal heart sounds can be calculated by normal Doppler. So the conclusion is high risk pregnancies earlier compromised 20% of all pregnancies, which has now increased to 40% because of sedentary lifestyle, because of nutritional deficiencies, whatever, because of non-healthy lifestyle. This has resulted in more preterm deliveries. High risk pregnancies beyond the age of 35 are characterized by, including hypertension, hypertensive disorders, obesity, underactive thyroid or overactive thyroid, anemia, diabetes, These are all the complications you see more than beyond the age of 35 years. So always concentrate on lifestyle factors such as alcohol and tobacco should be curtailed, and obesity. Always concentrate on patient should be given sufficient information about antenatal exercises, should be stressed upon walking and exercises, and fatal conditions such as preeclampsia, eclampsia, sudden increase in blood pressure which can affect kidneys, liver and brain should be known. So these are all the factors. I know that each and every factor is itself a topic which is a vast topic which can't be covered in 1 hour, but what is important, what is relevant in our day-to-day practice, I think as I have covered almost, but because of lack of time I couldn't cover many topics in this. And thank you once again for patients listening, and for thank you for the Shield Healthcare for giving me this opportunity. So thank you once again.
Thank you very much, madam, for discussing such a nice and very important topic. Just give me 1 minute time, ma'am, to check the questions in our dashboard.
Yeah.
Madam, one question is how to tackle this fatal tachycardia in the first USG if you found. So what will be the treatment approach for that?
Fetal tachycardia, always if you see the patient with fetal tachycardia, make sure that the patient is not in tachycardia. I mean, the maternal pulse rate should be calculated. If the maternal pulse is also more than, is consecutively in tachycardic condition, make sure the patient is not in anxious condition. Make sure the patient has no hyperthermia or no risk factors. And again, concentrate if the temperature is on rise, give paracetamol tablet. I mean, hyperthermia, patient goes into tachycardia. And one more thing is, if the isolated tachycardia of the baby, you need not worry until if the patient had any history of complications such as IUGR or excessive baby movements or anything as such. So rule out the cardiac malformation. So ask your radiologist, ask your radiologist to go for fetal echo if it's in second trimester. First trimester, you did not worry because fetal cardiac malformations, only minor things can be known. So fetal echo in second trimester at 26 weeks can be advised. But even if it's normal, one case I have encountered fetal tachycardia in a case where the patient had, the baby had minimal pericardial effusion. So that patient have referred to interventional cardiologist. So they have given some steroids and the patient is now very good. Is doing well.
Thank you very much, madam. And what will be the treatment approach in case of this second trimester hypothyroidism?
Second trimester?
Hypothyroidism. If a patient is diagnosed.
Hypothyroidism, irrespective of trimester, the thyroid status should be, as I have already said, these are all overt hypothyroidism. Hypothyroidism, these are, if the TSH levels always should be less than 2.5 to, less than 2.5 should be kept in mind. So second trimester, first trimester, third trimester, whichever trimester, always keep in mind that the TSH levels should be less than 2.5 to 3. 2.5, it's okay. So start levothyroxine if you have any doubt of hypothyroidism, but make sure that repeat TSH level should be done after 4 to 6 weeks, because the levothyroxine treatment should be adjusted. The dose should be adjusted accordingly, because TSH level should be always less than 2.5 to 3. But if you suspect only overt, subclinical hypothyroidism, go for free T4 levels. Free T4 levels should be calculated. If free T4 levels are also on increased trend, then that case should be diagnosed as overt hypothyroid.
Thank you very much, ma'am. Ma'am, another questions. Hello.
Yeah.
Yes, ma'am. Another question is, ma'am, if a patient is already in metformin during this insulin resistance for PCOS or something, and meanwhile she got pregnant, so that metformin should continue or should stop? What is your opinion on that?
Metformin has no, relevant side effects as of now. Some studies have shown that metformin has fetal risk factors, but most of the studies suggested that metformin comes in type B, type B drug. That is, you can safely prescribe metformin in pregnancy.
So thank you very much, madam, for this wonderful presentation and for such a nice discussion. I could not find any other question. So thank you once again, ma'am, for your valuable time on our platform Shieldconnect. So if you allow us, then we can conclude this session.
Yeah, thank you.
So thank you once again, ma'am, for your valuable support. And in future also, we look forward for some valuable session with you.
Thank you.
So thank you very much.